Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
Welcome back to the Deep Dive. Today we're diving into a request from a listener who wants to know more about the clinical prediction rules for pulmonary embolism.
Yeah, great topic.
And to help us navigate this complex area we have with us, Dr. Monica, an expert in emergency medicine.
Happy to be here. Thanks for having me.
So, the listener specifically wanted to dig into this article, Clinical Prediction Rules for Pulmonary Embolism, a systematic review and meta-analysis.
Oh, okay.
Before we jump into those rules, can you give us a quick overview of why PE is such a big deal in the ER?
Sure. So PE, or pulmonary embolism, is basically a blockage of one of the arteries in the lungs. And it's usually caused by a blood clot that travels from somewhere else in the body, most commonly the legs.
Interesting.
And it's surprisingly common. It's actually the third most common cardiovascular disease worldwide.
Wow. Third, I knew it was prevalent, but that's higher than I would have guessed.
Yeah, and the tricky thing about PE is that the symptoms can be really vague, like shortness of breath, chest pain, maybe a rapid heart rate. So it can be easily mistaken for something less serious, and that's why these clinical prediction rules are so important to help us assess risk early on.
So let's get into those rules then.
Okay.
I know there are a few different ones out there, so can you walk us through how they work and what makes each one unique?
Absolutely. So the most commonly used clinical prediction rules are the Wells, Geneva, and PERC rules. And they all aim to estimate the pretest probability of PE.
Okay.
So basically, how likely is it that a patient has a PE before we do any further testing?
So it's like a first-line assessment tool to kind of guide our decisions.
Exactly.
So what kind of criteria do these rules look at?
So they all consider a combination of factors, but each one emphasizes different things. So for example, the Wells criteria awards points for symptoms like leg swelling, recent surgery or immobilization, previous DVT or PE, and whether PE is the most likely diagnosis.
So Wells really focuses on risk factors and the physician's judgment.
Exactly. It's really trying to gauge the overall clinical picture, and then we add up the points, and that gives us a score.
Got it.
And a low score means PE is less likely, while a high score suggests a higher probability.
Okay, and so how does that score translate into action? What do we do with that information?
So if someone has a high Wells score, meaning 7 or more points,
Okay.
it usually means we need to move straight to imaging, typically a CTPA, to confirm or rule out PE.
So high probability warrants a definitive test.
All right.
What if the score isn't that high?
Well, for a moderate Wells score, which is 5 or 6 points, we might first order a D-dimer test, which is a blood test that looks for evidence of clotting.
Right, I've heard of that.
Yeah.
So a normal D-dimer can effectively rule out PE in those moderate risk cases.
It can, particularly when combined with a low or moderate pretest probability.
Okay.
It's a really valuable tool because it helps us avoid unnecessary CT scans, which, expose patients to radiation.
Absolutely. Minimizing radiation is always a good thing. Now, you mentioned the Geneva score earlier.
Yes.
What distinguishes that one from Wells?
So Geneva also assigns points based on clinical factors, but it gives more weight to the patient's age and heart rate.
Okay.
It's a bit more complex with a score ranging from 0 to 14.
So a wider range of scores, okay.
Yes. And for Geneva, scores of 2 or less are considered low probability, 3 to 10 are moderate, and anything 11 or higher is high probability.
Oh,
And just like with Wells, a high score usually leads to CTPA, while a moderate score might warrant a D-dimer test.
so both Wells and Geneva essentially serve the same purpose. They help us stratify patients based on their risk of PE.
Yes. And studies have shown that they both have good predictive accuracy, particularly in the fast-paced environment of the ER.
Right.
Ultimately, the choice between the two often comes down to clinician preference and which one they're most comfortable using consistently.
Consistency is key, for sure. But I know there's another rule you mentioned earlier, the PERC rule.
Yeah.
What's the story with that one?
So the PRC rule is a bit different. It's not about predicting the likelihood of PE, but rather about ruling it out
Oh,
in patients who are considered low risk.
interesting. So it's a tool for exclusion rather than prediction.
Exactly.
So what kind of criteria does it use?
So the PRC rule looks at 8 specific clinical variables.
Okay.
For instance, is the patient younger than 50? Is their heart rate below 100? Is their oxygen saturation above 95%? It also considers things like whether they have any history of DVT or PE, recent trauma or surgery, or if they're taking estrogen-containing medication.
So a combination of demographics, vital signs, and risk factors.
Exactly.
So what happens if a patient meets all 8 PERC criteria?
If they tick all those boxes, the likelihood of them having a PE is considered so low that we can often safely forego further testing.
Wow, that's pretty powerful. It can really help streamline our decision-making and avoid unnecessary testing in those low-risk patients.
Exactly. And it's a valuable tool for reducing unnecessary healthcare costs and avoiding potential harms associated with imaging or unnecessary treatment.
This is fascinating stuff. We've covered a lot of ground already, but there's so much more to explore.
Yeah, definitely.
Join us in part 2 of this deep dive, where we'll delve into the fascinating world of venous anatomy and uncover why understanding it is crucial for diagnosing and managing PE effectively.
Sounds good. Welcome back.
Time to dive even deeper into pulmonary embolism. And this time we're heading into a realm I find particularly fascinating, the intricate network of veins in our body.
Venous anatomy is often overlooked, but it's really crucial to understand how PEs develop and how they present clinically.
Yeah, it's easy to forget that a PE doesn't just magically appear in the lungs, right? It starts with a clot forming somewhere else, and that journey through the veins is key to understanding the whole picture.
Exactly. Most often that journey begins in the deep veins of the legs or pelvis. We call these deep vein thromboses or DVTs.
So essentially a DVT is like the prequel to a PE. It's the first chapter in this story of a traveling clot.
I like that analogy, and understanding that journey helps us anticipate where a clot might end up and what kind of impact it might have.
So let's say a clot breaks free from a DVT in the leg.
Okay.
What happens next? What's its path to the lungs?
Well, it travels through the venous system, making its way up towards the heart. It passes through increasingly larger veins, eventually reaching the right side of the heart.
And from there, it gets pumped into the pulmonary arteries, which carry blood to the lungs.
Exactly. And if that clot is large enough, or if there are multiple clots, it can get stuck in those pulmonary arteries, blocking blood flow to a portion of the lung.
And that's when we see the classic symptoms of PE, shortness of breath, chest pain, all those other signs we talked about earlier.
You got it. But here's where venous anatomy gets really interesting. The location of the original DVT can actually influence the severity and presentation of the PE.
That makes sense. I imagine a clot forming in a larger vein would have a bigger impact than one from a smaller vein.
Exactly. For instance, a clot originating in the iliofemoral vein, which is a large vein in the groin, is more likely to cause a massive PE, which can be life-threatening.
So knowing where the clot came from can give us clues about how serious the PE might be.
Yes, and it can also help us anticipate potential complications. For example, clots that travel from the pelvic veins are more likely to break up into smaller pieces, increasing the risk of multiple emboli lodging in different parts of the lungs.
So it's not just about finding the clot, it's about understanding its origin story and how that story might influence the course of the PE.
Absolutely. Now, shifting gears a bit, I want to highlight something that really stood out to me in that meta-analysis you mentioned earlier.
Okay.
It delved into the disparities in PE outcomes between men and women, and the findings are quite concerning.
Yeah, I was struck by that too. It's unsettling to see that women tend to have higher in-hospital mortality rates from PE.
Right.
Why is that?
Well, the exact reasons are still being investigated, but there are a few hypotheses. One possibility is that women might experience delays in diagnosis.
I wonder if that's because their symptoms are often atypical or because they're more likely to have other health conditions that could cloud the picture.
Those are both possibilities. Women might be more likely to present with less obvious symptoms like fatigue or dizziness, which can easily be attributed to other causes. And they often have multiple comorbidities, which can make it more challenging to pinpoint PE as the culprit.
So it's not just about recognizing PE in women, but also about being extra vigilant for potential complications.
Exactly. We need to be aware of these gender disparities and advocate for prompt and thorough evaluation in women presenting with potential PE symptoms.
It's a powerful reminder that we need to consider the whole patient, including their gender and individual risk factors when assessing for PE.
Absolutely. Now let's talk about another piece of the puzzle that's critical for assessing PE severity: biomarkers.
Biomarkers? You mean those blood tests that give us clues about what's happening inside the body?
Precisely. Certain biomarkers can be incredibly helpful in gauging how the heart is coping with the stress of a PE.
So are we talking about those classic heart attack markers like troponin?
Troponin is definitely one of them. Elevated troponin levels can indicate that the right ventricle of the heart is being strained.
Okay.
which can be a sign of a more serious PE.
That makes sense. If the clot is large enough, it's going to put a lot of pressure on the right side of the heart as it tries to pump blood through those blocked arteries.
Exactly, and that strain, if severe enough, can lead to right heart failure, a serious complication of PE.
So it's not just about finding the clot.
Uh-huh.
It's about assessing the impact that clot is having on the heart.
You got it. And in addition to troponin, we also look at other biomarkers like heart-type fatty acid binding protein, or HFABP, which can also provide insights into right ventricular dysfunction.
So biomarkers give us a more nuanced understanding of the severity of the PE and can help guide our treatment decisions.
Precisely. They can help us identify those patients who might need more aggressive treatment like thrombolysis to break up the clot, or who might need closer monitoring in the hospital.
This is all incredibly valuable information, and I'm sure our listener is starting to see just how complex the world of PE really is. But we're not done yet. Join us in Part 3, where we'll explore some additional insights into PE diagnosis and delve into the delicate balance between clot burden and right ventricular dysfunction. Welcome back to the Deep Dive. We're wrapping up our exploration of pulmonary embolism, and this has been a real eye-opener for me.
Yeah, definitely a condition that keeps us on our toes in the ER.
Yeah.
There's always more to learn and consider when it comes to PE.
Absolutely.
Okay.
So before we wrap up, I want to circle back to those clinical prediction rules.
Okay.
We've talked about Wells, Geneva, and how they help us assess the likelihood of PE, but you mentioned another rule earlier, the PERC rule,
Right.
which takes a different approach. Can you remind us how that one works?
Sure. The PERC rule isn't about predicting PE. It's about ruling it OUT.
Okay.
In patients who are deemed low risk, it's like a safety net to help us avoid unnecessary testing.
Right. It's all about being judicious with our resources and minimizing potential harms. So how does the PERC rule actually work in practice?
It uses 8 very specific criteria to evaluate a patient's risk.
Right.
These criteria include things like age, heart rate, oxygen saturation, and whether they have any history of DVT or PE, recent trauma or surgery, or if they're taking estrogen-containing medication.
So it's looking at a combination of demographics, vital signs, and risk factors to paint a picture of the patient's overall risk. What happens if a patient meets all 8 PERC criteria?
If they meet all those criteria, we can be fairly confident that PE is highly unlikely, and in many cases, we can safely avoid further testing.
Wow, that's incredibly helpful, especially in a busy ER setting where we're constantly trying to prioritize resources and make quick but accurate decisions.
Exactly. It allows us to focus our attention on the patients who are truly high risk and need more immediate intervention, but it's important to remember that the PERC rule isn't foolproof.
Right.
There's always a small chance that a patient might meet all the criteria and still have a PE.
That makes sense. No rule is perfect, and clinical judgment should always play a role. So let's say we've assessed a patient using these clinical prediction rules and decided further testing is warranted. What's a gold standard for diagnosing PE?
The gold standard is a CT pulmonary angiogram, or CTPA.
Right.
This is a specialized imaging test that allows us to visualize the pulmonary arteries and see if there's a clot present.
Right. I've seen those images. They're quite impressive. You can actually see the clot lodged in the artery.
Exactly. It's a very accurate test, but it does come with some risks.
Sure.
It involves exposure to radiation, and the contrast dye we use can sometimes cause allergic reactions or kidney problems.
So it's not a test we take lightly. We have to weigh the benefits against the potential risks for each patient.
Absolutely. And that's why those clinical prediction rules are so important in helping us decide who really needs a CTPA.
Okay, let's imagine we've confirmed a PE diagnosis.
Okay.
What happens next? How do we manage these patients?
The cornerstone of treatment for PE is anticoagulation. Essentially, we use blood thinners to prevent the existing clot from getting bigger and to reduce the risk of new clots forming.
Right, so we're trying to stabilize the situation and prevent things from getting worse. What kind of blood thinners are typically used for PE?
There are several options, and the choice depends on various factors, including the patient's overall health, their risk of bleeding, and their preferences. Some common choices include heparin, warfarin, and the newer direct oral anticoagulants, or DOACs.
I've heard those DOACs are becoming increasingly popular. What's the advantage of using them over the older blood thinners?
They're much more convenient for patients because they don't require regular blood monitoring like warfarin does.
Okay.
They also have a lower risk of bleeding complications.
That sounds like a win-win,
Yeah.
but I imagine the choice of anticoagulant is still a complex one.
It is.
And it's not a one-size-fits-all approach.
You're absolutely right. We have to consider each patient's individual circumstances and tailor the treatment accordingly. And it's not just about choosing the right medication. We also have to consider the severity of the PE.
Right, because not all PEs are created equal.
Right.
Some are more serious than others.
Exactly. We classify PEs based on their risk, with categories ranging from low risk to high risk. High-risk PE, which is often associated with hemodynamic instability, might require more aggressive interventions like thrombolysis, where we use medications to break up the clot directly.
So it's like a spectrum of treatment options depending on the individual patient and the severity of their condition.
Exactly. And this highlights the importance of a thorough assessment, careful risk stratification, and ongoing monitoring to ensure we're providing the most appropriate care.
This has been an incredibly insightful deep dive into the world of pulmonary embolism. I feel like I've gained a much deeper understanding of the complexities of this condition, from the initial assessment to the intricacies of treatment.
It's been my pleasure to share my insights with you and your listeners.
And to our listener, we hope this deep dive has equipped you with the knowledge you were seeking. Remember, this is just a starting point, and we encourage you to continue exploring this fascinating and ever-evolving field. And to everyone listening, thank you for joining us on the deep dive. We'll see you next time for another fascinating exploration into the world of knowledge.
Thanks so much for joining us today on the Emergency Room podcast. Please smash that like button. It helps us reach more colleagues and keep the educational content coming. Don't forget to share this video with your fellow healthcare professionals. And if you're not already part of our community, please subscribe to the channel and hit the bell notification so you never miss out on our next cutting-edge discussion. We're dedicated to providing the most up-to-date, evidence-based information to keep you at the forefront of emergency medicine and critical care.